of course, as always, what we say, we find a point of intersection between the two complaints. But truth of the matter is, these complaints could either be it's one of the following possibilities. Maybe these two complaints are related, and they explained by the same pathology, or they just happen to occur simultaneously, but they are from two independent pathologies. But many times what we do is we try to find one common pathology that can explain all the complaints that a patient has. And if we fail to do that now, we consider the other possibilities. So the things that I would be interested to hear about the duration of these symptoms, which is not here, and many other characteristics. But otherwise, especially for joint pain, I think I should say that there is a number of important things that I'll need to hear before I start throwing out some differentials. For example, the number of joints involved, um, the pattern of joint involvement, if it's symmetrical or asymmetrical, and if it's associated with some symptoms that would make me think that we are dealing with an arthritis, especially inflammatory arthritis or something else. And then when we come to cough, again, many times we like to think that the cough that is reported by a patient is mainly explained by respiratory pathology. Of course, cough itself occurs in the respiratory system, but then many times it's due to respiratory pathology, but it can be from a pathology outside the respiratory system causing the cough. So I think I still need to hear some more details in order to start and tease out what is going on with the patient.
Okay, sure. So we'll divide the HPI into two parts because the complaints are two. And let's start with joint pain. So she says that she started noticing gradual onset of joint pain 10 years ago. And it involved the hands, wrists, and later involved the feet. So the pain is persistent, but there are episodes when it becomes severe, and at that time it is associated with swelling and warmth. She reports on and off subjective fevers and chills. It is associated with morning stiffness that lasts for about an hour, and she denies back pain, neck pain, skin rash, eye pain, or photophobia. In terms of cough, this started 3 years ago. It is dry in nature, it worsens during the night, and it is associated with easy fatigue, and sometimes she hears wheezes. She reports shortness of breath during exertion, but none at rest, and she denies chest pain, weight loss, night sweats, and that's HPI. David, you're muted.
Okay, so let's start from the top. This patient, uh, is has been having a long-standing history of joint pains, and these joint pains. So, like I said, when we discuss of joint pain, I think it's very important to ascertain a number of things, especially some of the things that I talked about, like the number of joints involved. So from these that have been reported here, I think we have some preliminary information that we can work on, and then also the pattern, especially symmetry, but then some other associated features which I'm going to mention here. They have been highlighted. So joint pain can come due to many things. Joint pain can come due to many things. So, and these can range from infections, but then an infection, we do not expect an infection to to last for 10 years, an infection of joints, and to involve so many joints at once. So the number of joints involved itself can give you some differentials, like can give you some differentials. So, for example, if someone is just having one joint pain, or less than a certain number of joints, which we call oligoarthritis, then we tend to think of some differentials like so if we establish that it's so, you can talk about something like infective arthritis, you can talk about an acute gouty arthritis, reactive arthritis if the number of joints involved is one, or if it's a small number of joints. But then if we have many joints involved, and so what I'm mentioning is, after establishing that this joint pain is inflammatory, and what tells you that the joint pain is inflammatory? So when you see that there is swelling and there is warmth, you know there is inflammation going on. And then when it is associated with morning stiffness, we know that this is an inflammatory arthritis. So for an oligoarthritis or monoarthritis is the differentials that I've mentioned. But then when we talk about many joints being involved, then we start thinking about an inflammatory polyarthritis. And an inflammatory polyarthritis includes things like rheumatoid arthritis. You think about many of the connective tissue diseases that you know that can present with joint pain, including diseases like inflammatory myopathies like dermatomyositis and polymyositis. They can also present with joint pain. So those are differentials. But then when it comes to the pattern of joint involvement, we normally tend to think that if you see more small joints being involved, especially joints of the hands, then rheumatoid arthritis is one of the things that we consider. So at this point, what I'm thinking, we see a chronic history. So this is something chronic, and it started involving the hands. So basically, it's the small joints of the hands, like phalangeal joints, proximal interphalangeal joints, or distal interphalangeal joints, and then it also involved the wrists and the feet. And I also discussed that this is most likely inflammatory due to the swelling and warmth that is periodic, and the fact that the patient is also experiencing some fevers and chills. One of the possibilities is that it's because of the inflammation that is going on. And then this joint pain not being associated with back pain, rash, eye pain, photophobia. So there's a number of things that can be ruled out here. But then, of course, many joint diseases can present with this. So, for example, some spondyloarthritis do present with uveitis. And the uveitis is what can explain eye pain and photophobia. But then the spondyloarthritis are the ones which are more commonly associated with inflammatory back pain, which is not present in this patient. So let's see the next complaint. Okay, so cough itself, chronic again, more than 3 years of cough, which is dry, worsening during the night, and associated with easy fatigue, sometimes wheezes, shortness of breath during exertion, but no chest pain, weight loss, or night sweats. Okay, so for this cough, cough can be due to many things, as I said earlier, all the way from infections, airway diseases like asthma and COPD, interstitial lung diseases, and it can also be due to pathologies outside the respiratory system like gastroesophageal reflux disease or medications like ACE inhibitors. So for this particular patient, this cough is chronic, it's dry in nature, worsens during the night, and sometimes associated with wheezes. So this cough that is worse during the night and sometimes associated with wheezes, I think a reflex is to think about some airway disease like asthma, especially asthma presents with commonly nocturnal cough and wheezes. But then when I step back and think, because I'm making some assumptions here, we are dealing with a patient who most likely has an inflammatory polyarthritis, and then it's associated with cough with some dyspnea, but this dyspnea is present on exertion. So commonly, if I entertain my assumption that we are dealing with an inflammatory polyarthritis, diseases like rheumatoid arthritis and other connective tissue diseases are commonly associated with interstitial lung disease, and therefore, if it's interstitial lung disease, you do not expect anything in the airway. So wheezes are telling you that we are most likely dealing with an airway disease. But then, of course, I've heard about connective tissue diseases presenting with some pathologies in the airway. So I'm most likely thinking that we are probably dealing with an interstitial lung disease, but there is a possibility that there is an airway component. So yeah, that's where I am right now. I'm thinking that we are probably dealing with an inflammatory polyarthritis, and I'm thinking that the joint pains and the cough are most likely related and explained by one pathology. But then I can refine my thoughts based on other components of the history and physical exam.
I like that. That's so nice approach. So let's proceed. And if you have other system non-significant in GIGU, neuro, and past medical, this patient is hypertensive, not on medication. She's also having dyslipidemia, also not on medication. Her meds included as needed ibuprofen, and also she told me she would use prednisone as needed when ibuprofen wouldn't work sometimes. Family and social history: her mother, her sister, and her niece, who is the daughter of her sister, they all have joint pain, like small joint pain, pain in hands and feet. And she's a lifetime non-smoker. She doesn't drink alcohol, and that's it.
Okay, so I think I already took a lot of time discussing the HPI, so I'll just add a few thoughts here. So one other thing that I did not mention, of course, I think I'm not exactly trying to commit, but piecing together the puzzles. So again, the age of this patient. So some connective tissue diseases are more likely in this patient than others. As we like to think, many autoimmune diseases are more common in females of reproductive age. This patient is 66. She started presenting with the joint symptoms 10 years earlier. So when she was around 56, which is 56, it's way above the reproductive age, depending on the references you use. So some use 15 to 49, some 15 to 44. So it was already, I like to think, after it was postmenopausal. So, but an occurrence of an autoimmune disease in a postmenopausal woman, I wouldn't say it's completely impossible. So, but diseases like rheumatoid arthritis, of course, the incidence increases with age. So I think she's in that age category where rheumatoid arthritis is common, maybe more than other autoimmune diseases like SLE, and maybe we do not think more about the others that I mentioned, like inflammatory myopathies, because we do not have any witness, we did not hear any neurological symptoms in this patient. Now, the hypertension, we are not sure for how long, but we see that this patient has been using prednisolone on and off, I believe. But we know prednisolone, among other things, apart so prolonged use, especially of prednisolone, it can elevate the blood glucose, it can increase the weight, but it can also cause an elevation in blood pressure. So I'm not sure what exactly, maybe it's due to delays in diagnosis, but if it turns out to be rheumatoid arthritis, I think that's why it's crucial to diagnose these patients early and keep them on DMARDs rather than keeping them on long-term prednisolone, which comes with all these attendant complications. Yes, so, and again, we see that some female relatives, first-degree relatives, the mother and a sister, also have the same presentation. So, I mean, yes, it's. I believe there is a familial component. We couldn't say that rheumatoid arthritis is an inherited disease, but of course there is a genetic component to many diseases. So we like to think of nature and nurture. So yes, I think that by itself, a family history of a joint disease does not necessarily increase my confidence that we are dealing with a specific joint disease. But so we know that some diseases at least have a familial component. Maybe that's what can explain it. So yes, the hypertension itself, I'm still wondering if it's a consequence of the medications that she's using, especially the steroids, or if she has primary hypertension. And of course, hypertension may not explain the joint symptoms, does not explain the joint symptoms. But then, if we are dealing with hypertensive heart disease, um, then the cough and the exertional dyspnea can be explained by hypertension. But I'm still entertaining the hypothesis that the joint pain and the cough are tied together. Okay, so other details.
Sure. So we move on to the exam, and she was alert and oriented. She was a febrile, not pale, not jaundiced. She had some pretibio PT lower limb edema, but no lymphadenopathy. Her vitals, elevated blood pressure 170, 102. Pulse was 78. The respiratory rate was 22. The temperature was normal, and she was sitting normally in room air. Musculoskeletal exam. So both wrists were somewhat fixed, and she couldn't fully extend or flex them. And this was more in the left than the right. And also, the left wrist was deviated to the lateral side, and there was swelling of on the medial side. Also, she had symmetrical tenderness of the metacarpopharyngeal joints, wrist joints, and the metatarsopharyngeal joints, and the ankles bilaterally. Chest, she had crepitations and on both infrascapular regions, and then she also had some wheezes. For abdomen, it was non-distended, non-tender, but the spleen was palpable at 2 centimeter below the left costal margin. But cardiovascular system and neuro, these were normal.
Okay, so starting with the general exam, the patient has lower limb edema. Now, what we've been talking about, what can explain the lower limb edema? So yes, we know many connective tissue diseases can affect the kidneys, leading to can affect the kidneys, renal dysfunction. But then, up to a point where a patient presents with lower limb edema, that means they already have fluid overload, and therefore maybe would hear some other symptoms like a reduction in urine output or similar stuff, which we did not hear in this patient. Cardiovascular system examination is normal. Of course, that does not completely rule out a possibility of heart failure. So I think heart failure is another thing that we need to consider. But another possibility is The steroids by themselves, I believe they have another side effect of fluid retention, which can cause the lower limb edema that we see in this patient. Of course, if she has been using the steroids maybe recently prior to the exam, and then this patient is having uncontrolled hypertension. Other vital signs I see they are normal now. The musculoskeletal system exam. Can I see that slide? Yeah. So there are some signs here. The wrists are fixed. So of course, if someone is having an undiagnosed connective tissue disease, especially something as aggressive as rheumatoid arthritis, because I think so something that is unique to rheumatoid arthritis among the connective tissue diseases is that it's very erosive as compared to the others, and at least from the limited knowledge that I have about other diseases like SLE, they do present with joint symptoms, but the presentation in the joints is non-erosive. So you find someone with SLE, most likely, if it's SLE by itself, most likely they will come with the inflammatory arthritis, but you are not likely to find joint deformities. These joint deformities for me increase the confidence that I'm probably dealing with rheumatoid arthritis, because that is the one that I know that can be that much erosive. So, and of course, if rheumatoid arthritis is not treated, and let's not forget this patient has been having these symptoms for more than 10 years. So, of course, that's enough time to cause the joint destruction that we see in this patient. The wrist being deviated to laterally. I believe there is a name for this sign. I do not remember the name. Maybe if Joseph remembers, he'll tell us later. But again, I think it's another thing that is very classic for rheumatoid arthritis. And small joint involvement, MCP, of course, uh, we know there are some distal interphalangeal joints, proximal interphalangeal joints. You see those, they increase confidence in rheumatoid arthritis, but of course, even the other, the small joint involvement, I think for me, is more calling for rheumatoid arthritis than the other inflammatory myopathies that we know. And then coming to the respiratory system, there are crepitations more at the bases. So this could be anything. It could be pulmonary edema, but then, I mean, for pulmonary edema, maybe our patient could be more restless than the general exam itself would be more dramatic than the way it has been presented here. Maybe the patient would have a low oxygen saturation, and they would be in respiratory distress, which we've not been informed about here. So I'm thinking these crepitations are most likely due to an interstitial process that is going on in association with the connective tissue disease that we are dealing with. And then the wheezes, like I said, wheezes are more in keeping with an airway disease, uh, where there is a degree of bronchoconstriction. That is what will present with the wheeze. So commonly, when we talk about rheumatoid arthritis and other connective tissue diseases, we talk about an interstitial process or serositis, which is involvement in the pleura. Not commonly talking about the airways. So I think this will be something new that maybe Joseph will explain more to us later. But I remember hearing about a case of a patient who had an autoimmune disease with respiratory manifestations, and it turned out that the airways were also involved. So I believe this is probably the case here. And then on abdominal exam, we see that there is splenomegaly. So commonly when we talk about when we talk about these diseases, like yes, the autoimmune diseases, we do not talk about splenomegaly commonly, but if you read about causes of splenomegaly or hepatosplenomegaly, some autoimmune diseases are also mentioned. And there is a specific subtype or phenotype of rheumatoid arthritis that presents with a triad. Now I do not remember the third component, but of course, so joint presentation, you have splenomegaly, and the other one I do not remember if it's in the respiratory system or not. But yes, there is a subtype of rheumatoid arthritis that presents that way. It has a name; it's an eponym. So I do not. I think I have to be careful here, but there are two names that come to mind. So there is Kaplan syndrome and there is Felty syndrome. I'm not sure which one, but Joseph will teach us later if he knows that. Other systems are essentially normal. So yeah, I think the joint, especially the MSK exam, what it has added to us is that the arthritis that we are talking about is erosive and very deforming, which increases my confidence for rheumatoid arthritis. So, labs, anything else that you have?
Yeah, very nice. Here are the labs. So the only thing that we saw
You're
was,
muted, Joseph.
oh, yeah, sorry. So this solo quote will be a bit long because of time, and I'll present the lab in the imaging that we have. So she had a slightly elevated WBC of 10.8, and absolute neutrophil count was reduced at 0.79, but other parameters of the FBP were normal, renal function were normal, liver normal, but ALP and GGT were slightly elevated. Her ESR was extremely elevated at 80, glucose was normal, rheumatoid factor came back positive, uric acid and cholesterol were also normal. I'll go on and present the imaging that I have. And here is one. I don't know if you can see anything, maybe. This is the x-ray of the hand, of the left hand that had more damage than the right. So I took an x-ray of it. And here's an x-ray of the chest. Hope you're seeing something. And lastly, she had an ultrasound which showed enlarged spleen at 6 centimeters. Yeah.
Okay, so I'll just try and discuss this very briefly. So there's a leukopenia, although the WBC count, of course, mildly elevated, so I won't spend a long time discussing this. The alkaline phosphatase and GGT elevated, which reflexively would say they are markers of cholestasis, but ALP can come from anything. Of course, when there is increased bone turnover, so for example, if someone is having massive bone destruction, we can also see an elevation in the ALP. So ALP, GGT, of course, in the biliary system, more commonly hepatobiliary system, something going on in the hepatobiliary system. But of course, in conjunction with what we are seeing, I'm thinking the ALP is probably because of the increased bone turnover. Of course, because of the joint destruction. ESR, right from the history, we knew that most likely this patient is inflamed because of the presentation that we had. So this ESR is not a surprise. Rheumatoid factor being positive, of course, very sensitive for rheumatoid arthritis, about 80% sensitivity, but not very specific because you can also have other things that can cause an elevation in rheumatoid factor, including some infections. So, of course, tallying this with the patient's symptoms, I think we increase our confidence that we are dealing with rheumatoid arthritis. Of course, you can order something more specific like anti-CCP and see how that turns to be. So yeah, in the labs here, I think that's what I would want to discuss. I'm not surprised that the ESR is elevated because the patient is inflamed, and then rheumatoid factor being positive increases that confidence of rheumatoid arthritis. Coming to the image, of course, I cannot pick all the things here, but especially so, one thing that rheumatoid arthritis can cause is so there's deformities in the joints and some newborn growths, and of course it can cause osteolysis, especially in the distal fragments, which we cannot see clearly because they almost towards the end of the image. But I have a suspicion that probably that's another thing that is going on. And then, especially coming to the couple bones here, I think radiologists are more of an expert, more of experts here. But if you look towards the end where the thumb is, so to your left, I see that there is a couple bone that is more sclerotic there. So probably it's because of an inflammatory process that is going on. So yes, generally I see deformities, and then if you look at the the proximal phalanges, you see again the towards the radial aspect, you see that the joints toward the periphery are like they are destroyed. So I'm thinking this is the joint destruction of rheumatoid arthritis, most likely. Coming to the chest X-ray, yeah, this chest X-ray is not clear. You can see that more at the bases, there's this heterogeneous opacification both on the left and right. I would say it's more prominent on the right with almost obliteration of the costophrenic angle on the right. So it's a process that is more predominant on the bases, a heterogeneous opacification more on the lung bases. That is what I see, especially more on the right than the left. Which again is not very specific. I wouldn't say that this is specific for the pathology that we are thinking about, but this could be an interstitial process that could come with anything. An atypical pneumonia would give you this, but then in the context of this patient, I'm thinking this is an interstitial process. You have anything else, Joseph?
Yeah, ultrasound.
Yes. So the spleen, I think I already talked about this. Now, is there something else that can explain this? We have splenomegaly, because yeah, maybe I should take time thinking about this spleen in order to not miss anything. So if you see the spleen is enlarged, there is a number of things that you think about. Joseph talked about this. I believe he discussed the splenomegaly sometimes. So the spleen could be filled with water, as in a case of portal hypertension. We do not have a suspicion for that in this patient. The spleen could be filled with cells. So, for example, so in hypersplenism, patients, interestingly, patients with autoimmune hemolytic anemia, for example, they do present with splenomegaly because the spleen is the primary site for destruction. So hemolytic anemias in general, not just autoimmune hemolytic anemia, which actually can occur outside the spleen with hemolytic anemia. So it could be cells and it could be molecules. So molecules like in Gaucher's disease and in many other diseases that you can think about. So could this spleen be due to something else apart from the rheumatoid arthritis that we mentioned, and I saw Michael help me here that the triad I was talking about is Felty's syndrome. So I mean, outside Felty's syndrome, and I do not remember the other components. So that is what I'm eager to learn about at the end. But could it be something else? I cannot think about something else that can explain this massive joint destruction and the splenomegaly. So if you think about, for example, a I mean a hematological process that's going on, like a myeloproliferative or lymphoproliferative process presenting with the splenomegaly, that was not reflected in the full blood picture, and I would not explain. I mean, you can try and think about a paraneoplastic presentation, but I'm yet to read about a paraneoplastic arthritis. Something like that could be existing. But again, even if it would exist, I wouldn't intend to think that it causes a massive destruction like we saw in the exam and in the imaging of this patient. So I'm putting my sense on rheumatoid arthritis most likely, but I'll be open to being surprised that I've missed some detail which lost me in my tracks. So anything else that you have?
Yeah, sure. So the reading of the imaging, I also did the same, especially the hand X-ray, the lateral couple bones like fused and the sclerotic. That's very. So how are you laboring this patient now?
Yes. So and I think right from the beginning, I think I committed very early. Although I was discussing about an inflammatory arthritis, I the joint deformity, especially on physical exam, and the small joint involvement right from the history, I think took me in the direction of rheumatoid arthritis, and I considered less other causes of inflammatory arthritis. So uh, yes, I think I'm more biased in that direction because of what we've seen so far. I'm thinking that this patient is having rheumatoid arthritis, and the splenomegaly that we see can be explained by this rheumatoid arthritis. The chest symptoms and the imaging, an interstitial process that is associated with rheumatoid arthritis. So, because I do not remember all the components of Felty's syndrome that I talked about, I know rheumatoid arthritis with a spleen. But then, what else in that triad? Is it the chest symptoms that we're talking about? I mean, interstitial lung disease. I'm not exactly sure. So I'm thinking the big umbrella is rheumatoid arthritis. I think I will loosely uh, throw in that eponym of Felty syndrome, but then I would have I would have to go and peruse in order to see if the patient has all the components of that in order to qualify for that syndrome. But the broad categories are rheumatoid arthritis with interstitial lung disease.
Yeah, yeah, very nice. So I also had the same thought, and I came up with the diagnosis like you are doing here, that this is seropositive rheumatoid arthritis with complications, extra-articular. One of them being rheumatoid arthritis ILD. I believe it should have been called probably rheumatoid lung disease, because not only ILD, as you alluded to, there are also airway disease, which we will see in the learning points that these things also exist. But more and more, rheumatoid arthritis, ILD. It's unfortunate this patient couldn't afford doing HRCT, which could have characterized more of her chest. And true, another is Felty syndrome. We'll learn what is the third component. But I appreciate your knowledge on this very broad and difficult diagnosis sometimes, rheumatoid arthritis. So I it's unfortunate. I think someone has thought about this because the person who prescribed prednisone to this patient could have thought of this maybe, or they have done and it was positive, but she didn't tell me she was ever told she has rheumatoid arthritis, and probably they didn't start methotrexate. So I initiated her on methotrexate. It's the lowest dose with rheumatoid arthritis 7.5, and I will be monitoring her to see if there is any response or increase the dose. So some points, starting with the Felty syndrome. We have learned rheumatoid arthritis in this platform several times, so I wouldn't go there again. But every day, something else comes up. For example, when I saw this case, okay, I knew about Felty syndrome, I knew about rheumatoid ILD, but there are other things that I didn't know, and then that's why I decided to present this case here. So they tried Felty syndrome, David. Seropositive rheumatoid arthritis, it can never be seronegative. And then neutropenia, this patient had an absolute neutrophil count very low, zero point 0.7 something. And again, splenomegaly, but splenomegaly is not necessary. Although most patients will have it, like more than 90%. But even if it is not there, if they have seropositive array and an unexplained neutropenia, you call it Freitas syndrome. And so the cause is not known basically, but it's thought to be due to chronic inflammation in some genetically predisposed individuals. The risk of patients with rheumatoid arthritis to develop Felty is 1%, but more of these patients are females, 60 to 80%. There are associated features. So this patient will present with recurrent bacterial infections because of absolute neutropenia, and more will be respiratory infections and skin and soft tissue infections. And they will also more likely to have other extraarticular manifestations of rheumatoid arthritis. For example, this patient also is having rheumatoid lung disease. They can also have portal hypertension. They are more likely to have malignancy compared to general population, which include lymphoma, lung cancers, and etc. How you treat it? Not so different with the rheumatoid arthritis. First of all, you prevent infection by making sure these patients are following a good dental and hand hygiene. They receive vaccination, and then DMARDs. But the preferred DMARDs here are two: methotrexate or rituximab. Others are questionable. And then, if patients still present with recurrent infection despite you starting them on DMARDs, you give them this granulocyte colony stimulating factor. So that is about the Felty syndrome. But rheumatoid ILD, this is the most common form of rheumatoid lung diseases, but others exist, including pleural diseases. They can have a fusion, for example. That X-ray is questionable. Maybe not any fusion that we're seeing on the right side. And they can have airway diseases like bronchiectasis, bronchiolitis. Maybe the wheezes that we're saying were from this. If we could have a CT, we would have been told about the thickness of the bronchioles. And then they can have rheumatoid lung nodules. The Kaplan syndrome comes here. Rheumatoid lung nodules, exposure to, I think, some exposure to inorganic material, and then rheumatoid arthritis. And then you can be giving them methotrexate for long, and then they have drug toxicity. Methotrexate itself can cause ILD. So someone can present because of long-term methotrexate and they have ILD because of methotrexate. But there are others, which include venous thromboembolism, pulmonary hypertension, vasculitis, which can cause multiple leg ulcers. I've seen a patient with rheumatoid arthritis, multiple leg ulcers, which is from vasculitis. But rheumatoid ILD is more common in males than females, 3 times more common in males. And the symptoms usually begin in their 50s to 60s. This is very important because someone can have ILD, and usually here in this country, patient with ILD, they just labeled ILD, usually no cause. So maybe you can take a trouble and send that lab, send a RIF, send anti-CCP, because ILD can come in without the joint symptoms. So the presentation, as we saw in this patient, they have excisional dyspnea, non-productive cough. Others can have fever, chest pain, etc. You need HRCT, by the way. It's unfortunate you couldn't get these patients. And when they have rheumatoid arthritis, ILD, there is no like proved therapies, but by experience, rheumatologists use rituximab and mycophenolate mofetil. And yeah, so that was it. This was an so we call them bread and butter case. Very nice. David tackled it in a very good way. So maybe David from you.
Thank you very much, Joseph. So again, I mean, every day something new comes up because I think this is not the first time we discuss a patient with joint pain, and so we would like to think that maybe over time it gets easier. Maybe it does, but then some new things come up. So, for example, when I was discussing the labs, I saw this neutropenia. But then, so just like we say that the eyes can't see what the mind doesn't know. So I saw the neutropenia, and of course, commonly you see neutropenia, that something is going on. Of course, either an infectious process or another inflammatory process can either cause neutrophilia or neutropenia. So, but I could not explain it. So that's a new learning for me. I think that completes. So I just had this vague memory of reading about Felty syndrome, knowing that rheumatoid arthritis is there, splenomegaly is there, and then I did not remember the third component that completes that triad. So I've learned about that today. So I think that's a big takeaway for me today. And then yes, another thing I think is just maybe that's one other reason why we do this, to improve our diagnostic skills, because you can see someone who was having joint symptoms for 10 years. I do not believe that she stayed at home for 10 years, and she would also not know how to start prednisolone on her own. So most likely she came into contact with the healthcare system and then was just started on prednisolone with no further steps being taken. And as the disease progresses without disease modifying and rheumatic drugs, uh, the disease becomes more severe, more aggressive, with the joint destruction that we see in these patients. So, end of the day, these patients end up with deformities that are very crippling, apart from the pain, but then they are crippled. They cannot go on with their day-to-day activities because of the joint stiffness that they have, reduced the joint mobility, not just from the pain, but the deformity. So I think it's imperative to improve our diagnostic skills, to have a high index of suspicion, diagnose these patients early, and then in case you can't, uh, you just need to vaguely know that something is wrong with this patient. So I think I need to send this patient to someone who might be able to diagnose what is going wrong. And then that way, these patients can be started on therapy early on in order to avoid the disabling joint deformities. So again, thank you very much, Joseph, for the case. I learned a lot from this case. Thank you very much, and I see Antimon has a hand. Antimon, if you have anything, you're very welcome. Antimon, I'm not sure if that was accidental. I saw your hand for quite some time. If you have anything, please welcome. Or if anyone else has anything, I think we still have some 5 minutes. So in case you have any question, any comment, anything to improve, please welcome.
Yeah, and it shouldn't go without mentioning. I should praise Dr. Michael Kisoka again. I saw him when we were discussing the other day on transverse myelitis. Seems to be very knowledgeable doctor. I like him. And Michael, if you wish, we welcome you here. One of the day you can discuss. We want to hear from you. It's a very free space, and most of us are learning here, and we believe we can learn from you. So just one day, tell us if you want to discuss alongside maybe one of us. it would be very, very nice because something like this you could have discussed it, and it would be maybe the same as David is doing here or more. Who knows?
Thank you very much, Joseph. And I'm here to learn also from you, seniors. I think I'm learning a lot from this side, and I will probably communicate with Dr. David one day for a discussion. And one point of addition to particular to the patient, not to the case has been discussed in detail. And I was thinking probably this patient also might need physio. As far as the X-ray, the way it has been, the carpal bones have been distracted, ulnar deviation, and then the caput ulnar syndrome. I will not say rather the carpal tunnel syndrome because the tests for neuropathies such as Fallon test have not been done. So probably this particular patient might need some sort of physiotherapy and the other issues to be channeled into the therapy. And I was thinking probably a little bit questions, and I was thinking of the guideline because we have what diagnosis for ILD, and yet we know that methotrexate can induce ILD, and yet we have methotrexate in our regime. I don't know from practice for you seniors, can we proceed with methotrexate or should we change to other DMARDs probably to this particular patient?
Yeah, thank you very much. First of all, I didn't even know that I should give this patient physio, but yes, that is very nice. Thank you. I will consider that. And so, yeah, as you saw, the treatment, rheumatoid arthritis ILD, no treatment, but by experience, rheumatologists use MMF rituximab. Very expensive. We cannot afford them, I believe, because this patient even to afford that HRCT, it was impossible. But again, so what do we have on the table? We cannot keep this patient on just as needed prednisolone. We have here the methotrexate. The only problem with methotrexate is when you see a patient who is having RIA and then they are having ILD, one of the possibilities that you should come up with, it is not just the disease, it is the drug that is causing the toxicity in the lung. But will it cause the toxicity in the lung just because now they're having already ILD? That I don't know. But as far as I can find something to give this patient to take her out of prednisolone, methotrexate is the one that she could afford. But if I had everything, yes, rituximab, MMF, that would have been the number one drug for this patient. So thank you very much. Yeah, Roland, very nice. I gave this patient folic acid. Very good, by the way, for reminding me. I forgot to write it there. Yes, so that to avoid the complication of methotrexate macrocytic anemia. Anything
Okay.
else?
Yes. Anyone with anything before we close? Okay. I do not see a hand. So thank you very much, everyone, for joining. Next weekend, I believe I'll have a case for Joseph because I've been discussing for a while, and I know for a fact that Joseph misses discussing. So I'll try my level best to come up with the case next week. So and I believe it will be very interesting because the case I want to bring is by itself very interesting. Sorry to spoil that, but to be very interesting. And I think you haven't heard Joseph in a while, so make sure to be here next week, and we'll share the link as usual. Again, very good to have you around. So this is encouraging. The sole purpose for creating this was to make sure that we learn every day, and so seeing people join without reminders, that is very encouraging. That people are self-driven to learn more and more. So let's keep doing that. And again, the call that we've been making all the time. So We already have a promise from Michael that we'll discuss one day. So very, very much looking forward to that.
It can be next week.
And we hope many more will come up to discuss cases, but also to bring cases. And maybe let's not think that a case has to be very complicated or very well clerked and investigated in order to be eligible for discussion. Yeah, just bring anything, because we need to learn, and especially to improve our clinical reasoning skills in general. So even if you have a case that is incomplete, a case that is disturbing you, puzzling you, you can have some inputs from here. So if you have any, reach out to me, reach out to Joseph, and we'll be sure to make a spot for discussing that case. So having said that, thank you very much everyone for joining. Have a good night and see you next weekend.
Good night, everyone.